Geeking Out Volume 1 is loading live. This is going to be great as we wait for Geeking Out Volume 1 to go live. Perfect. We're now live on the stream and nearly close to getting it on. We will soon be on the website for Geeking Out, which is a brilliant idea. Whoever decided to come up with this, I have to say, just too good. Just too phenomenal, however it was done, isn't it? And so that's what we are working upon. I am now simply going to put this on the website. I'm just going on to Geeking Out's control room. Just be aware. Ooh. Bear with us. As we go into the analytics module. Where is it going? Sorry, bear with me. So I do this last bit. Where is the embed gone? No, that's fine. Yep, you can see us now. That's about right. We'll be going live on the link now. Excellent. We're live on the Geeking Out link now, and everybody should be able to talk to us now. I will soon be introducing our guests for today's Tubules Live Together. This will be a great, fun, and enjoyable Geeking Out Tubules Live. But like we say, before we start any of this, it's always great to have a reminder of why and what we do. This is Tubules Live, beaming from Iceland. Well, welcome to this Tubules Live Together. We are doing this together while we're isolated. And today we're inviting the Geeking Out gang. I think the Geeking Out gang have had great fun. We have, as our team today, two members of the Geeking Out gang on video. Nick Setti, beaming from Essex. Nick, are you there?
Indeed I am. How you doing, everyone?
I hope everyone can hear him. If you can hear Nick, just put a comment underneath, put a comment to say, yes, Nick, we can hear you, because that will be very nice to know. We were told to isolate. We were told to stay as far away from everybody as possible. So today's main speaker decided to isolate in Barbados. Riaz, can you hear us from across the Atlantic?
I can. Please don't report me to the GDC or the CDO. I haven't been traveling during lockdown.
No, you were traveling before. The flight just didn't come back. And
I wish, but that we can play around with the virtual backgrounds.
It is true. It is true. My background is my T-shirt, the logo. Now, before we start today's Tubules Live, all of you watching this have to be aware. We'll be able to get CPD for this later. Especially the premium members on Tubules. What I've done is in your intelligent PDP on Tubules, I have already very nicely created a template. So if you go to your IPDP on the website, and once you've gone on your IPDP, just scroll down look at ED goals, go down to growth goals, go down to treatment planning in the post-COVID world, tick that, and scroll down and just add it to your learning cycle. This is now inside your PDP learning plan. When this Tubules Live Together is over, these are my goals, but you will be able to go into the online CPD section, do the usual method, and get your CPD. This is great for premium members. Your PDP, CPD will all be created and done today. So while you're isolating, your knowledge isn't isolating. That's what we do. Today, we officially and softly launched the Tubules Live Aid section. Tubules has been at the forefront of helping everybody in dentistry in this time of crisis. We did Tubules Live Aid, we did lots of useful things. This new section, it's free for everybody, free for anyone to view. We are going to host webinars, we're going to host discussion forums for you to discuss things that are challenging you right now, from things like pay, where do I start my practice, NHS, even things like, has anyone found the CDO? There'll also be webinars. You can see the ones coming from the Geek Out gang. Nick Sethi today and Riaz Yar today, and then we have Sanjay Sethi on Sunday. The Geek Out gang have 12 amazing, super duper live, Tubules Live Together webinars. So I hope you enjoyed that. My introduction, Tubules is here to help. We're all doing this together. So let's all stay together. Let's all beam together. Let's all work together. Over to the host for today, Nick. Nick, how did you start this Geeking Out? What made you think about it?
Hey, Drew. I'll tell you what, we went through the motions of this, getting used to what is going on in the world at the moment, you know, closing the practice, having to deal with all the team members and make sure they're looked after. And to be honest, I just got fed up of looking at spreadsheets, numbers, spreadsheets, contingency plans. I just lost the plot. And Riaz was giving me some advice about how to keep myself sane. And I said, mate, do you know what? Let's just do what we do best. Let's just come together, take a few topics which we found confusing back in the day. Well, he doesn't find anything confusing now. I still find most of it confusing. And we said, let's try and break things down. Forget 3-4 hour webinars. Let's just make fun 20-minute slots for things that people can understand, take away, and just get their minds off things like running the practice and doing all of that. So we're not going to take up a horrendous amount of your time, but we've come up with 12 different topics. Sanjay, Elaine, myself, and Riaz. We really hope you enjoy what we've got coming. And it's a real pleasure for us to start with someone who I had the pleasure of inviting to speak for us at Square Mile Dental Center last year. Riaz came in, I'd seen him speak before, and we were all blown away, not just by his passion, but just by how calm and how honest he was about his failures along the way, things that he'd found difficult. And he's just got a really nice way of explaining things to make things not complicated. He's, like I said, one of the most finest dentists in the country, just an all-around super chap. And today he's going to be looking at the 3 pillars of treatment plans and if patients are suitable for what we're planning. So without further ado, Riaz, I'm going to hand it over, put myself on mute, and I'll be here afterwards to match your beach background with my hat and my sunnies to have a bit of fun later. So Riaz, over to you, buddy. Take care.
All right, thank you, Nick. You know what? I'm lucky I don't blush, because if I did, I'd look purple and I just wouldn't look great with this background. I'm just going to share my screen and let's get started. Hi guys, I hope everyone's safe. I hope everyone's well. I know it's been a challenging time, and as Nick put it so well, we've just sort of tried to try and make the best of actually what has been challenging, but also I think now has become a bit more of a fun time. I don't think I'm ever going to get this time off again. I don't think I'm going to see that background again. So let's see what happens. So we've thought about how we can try and help you guys post-COVID, because treatment planning, I think, coming certainly in the next sort of 5 to 6 weeks, patients are going to start coming back into the practice, and we're going to start looking at the treatment plans that you gave them post or pre-COVID. And so the way I've always worked is using these 3 pillars. And I'm going to show you sort of presentations that I would give a patient at this stage, trying to get them to understand the pillars that we have as a practice. And then what we want to do is find an ideal plan for them that's affordable, but also fits within their suitability and their oral environment. So we'll get straight into it. And the desirability element will be just simple. Let's just understand what the patient wants. Now, you may have done that already, and you may have done your suitability score, but the biggest white elephant in the room now will be your affordability. It may totally change. And so helping you guys to get that structure and preparing you for when patients are going to come in and go, I can't afford that. You're going to need to think outside the box, still deliver the ideal desirability within the suitability, but now trying to find it so it's cost effective. Desirability is pretty straightforward. We all use tools to try and find out the patient's desires. So you can do a pre-assessment. It can be a smile questionnaire. I know we do psychological analysis, so you can look at sort of certainly their anxiety or stress level scores. You can look at their sleep patterns. We can really get to understand our patients before we start looking at anything complex or even something simple. And sometimes I think we sort of, the strap line was, you know, patient just wants a chip repairing, but that chip could be the cause of other things. So our job is to find out that, yeah, it may just be a simple chip and it may just be a composite, but it could be due to other things as well. And that's what we've got to help our patients understand. They want to know about function. They want to know that, you know, I know I have a list of patients who come in and they go, I just simply don't want my teeth to break anymore. They're not so interested in the aesthetic sides. That doesn't mean that we don't do it, but it means that they're not that interested in it. So they're more interested in function, predictability. Some of them may have some pain and just want control of that. And that is a challenge in itself, trying to control that pain. So risks, there's always risks to everything that we do. But our first goal is to just say, okay, do we really understand our patients? The way I look at my patients when it comes to suitability is I look at them like a jigsaw puzzle. So they come in, the more jigsaw pieces I have from them, the better the picture I have and the better the affordability I can discuss with them. And also, is this going to be a long-term maintenance goal for them? So I don't want to do complex work and then they can't maintain it. Or I don't want to do simple work and then they're coming back a year, 2 years later going, well, it's not lasting the way it was. So the key here is making sure that whatever we put in the mouth, that mouth is suitable for it. One of the things I do like to do always is find out what they do for a living. So sometimes you'll find someone who's head of HR or is a gardener, and I'll try and find an analogy to talk about their environment and putting things in that environment that needs to work, and it needs to be the right thing for that environment. So when we look at suitability, it is going to be a clinical examination. It is going to be your special investigations. I find photographs and smile design help a lot. And then if it's a more intriguing case that needs functional assessment, then I use something called ModJaw, which you'll see some videos of a bit later on. But that then comes to affordability. And what I tend to do is when I'm presenting it to the patient, I'm talking about the suitability, and I've told them that I know what their suitability is. I know what their desires are. So they may have said, I want aesthetics. That's their wish list. So what we do is we create the wish list of the patient. It may be predictability, it may be aesthetics, and it may be functionality. And then I'll say to them at this stage that, yes, I can actually deliver the aesthetic result that you want. I can actually deliver the functional and the predictable result that you want. And I'll tick those off for them. And I'll get straight onto the topic of affordability. And I'll approach it in that way, saying, look, I know affordability is one of the pillars, but actually it's the white elephant in the room. I know you're itching to know how much it's going to cost. So what I then do is, as I approach the affordability stage, is I say, look, you've got 3 solutions. And I always try and present the patient with three options: best advice, compromise, and the minimum that I will do as a clinician. And I'll put a price next to it, and it can be 5,000, it could be five, it could be 20,000. And I'm talking about treatment plans that are going to be into a couple of thousand. If you're doing a treatment plan for a couple £100, then that's probably the minimum or the best that you will do for that patient. So it doesn't need this amount of preparation for it. But what I'll say to the patient at this stage is say, this is the best advice, this is the compromise, this is the minimum. Which one of these treatment plans would you like me to go into more detail? And I think that's really important, because that then puts the onus on them to guide me, because I don't want to spend half an hour talking about best advice and they're going, well, my budget was always compromised, I could never afford more than £2,000. I'd rather them say to me, I can only afford 2,000, and then I will just simply bypass all the slides and go straight into what a compromise solution is. So if we look at sort of some cases, and I think photographs for your patients are going to be really important. They need to understand the challenges that we have and actually what's going on in their mouth. And I think that's really important in the current world, because patients are going to come in, and if they're starting to tell you they don't want the treatment plan that you've given them, 9 times out of 10 for me, that's because we haven't told them or given them enough information so they knew what our concerns are. So here I'm looking at tooth wear, we've got a crossbite issue here, we've got some gingival profile discrepancy. So these are things that I want my patient to know. I'm going to show them intraorally what the complications are. So it may be simple composites that you need to replace. You may want to do a little plan like this so they understand it, but this won't take too long to do, but it really will help the patient. So then they may go, okay, that's fine, I understand, I'm still happy to go ahead and do it. And I think that's really important. You'll see on the lower right, there's a missing tooth. So there's an option here for the patient to replace that missing tooth. We really want to talk about that and give them the information so that they can then make the best decision for their mouth. Here we've got lower incisal tooth wear, and that is because of the way the teeth meet, and I would have highlighted that straight away at the start. Smile design software, I like Smile Cloud by Florin Kafar. He was with DSD and he sort of branched out and created his own, and I find this a bit more user-friendly and cost-effective, and I like it. So this really does help the patient start to see the end result. Now, some of you may be already doing it, but if you're not, I think this is a good option for your patients, because we need to be now more proactive with them to help them understand what we can achieve. Now, this is a guide, and this is going to help me with measurements and so on, but we will still do a provisional stage if they decide to go ahead. But what I'm just doing at this stage is showing them what I think their smile could potentially look like. This is the wish list for that gentleman. So he's wanting aesthetics, he's wanting functionality, he's wanting predictability. So I'm going to then talk about the 3 options that we have. So the best advice in my mind for him would be to restore the upper arch and the lower incisors with a combination of ceramics and so it'll be full coverage and veneers. So that's my conversation with the patient at this stage. It's just is giving him the option, and he'll need some gum recontouring as well. But if he's already told me that he can't afford best advice, he's already going compromise, I wouldn't spend any time on this slide. I would just say, that's the best advice, but we know that's not what we want to do. So we're going to look at a compromise. And the reality is, when you go from best advice to compromise, the compromise is on aesthetics, predictability, and functionality. So I can still deliver an improvement, and it would mean just restoring a number of teeth rather than a full upper arch. So that makes it a little bit more unpredictable, but that's the minimum, guys, that I would do as a clinician for him. And if he's asking me to just do the lower incisal edge composites in that occlusion, that's not the minimum that I can do. He needs his OVD increasing so that we can correct that crossbite. some of you may have said, well, why isn't ortho? So in that suitability assessment, I would have straight away gone, you are an ortho case. And he's gone to me straight away, I am not having ortho. So for his age, he's going, I'm not going to be wearing a brace. That would be my best advice, but there's no point me presenting best advice if he's already told me I'm not having orthodontics. So that's not an option. So my then best advice, not involving orthodontics, is restoratively increasing his OVD and doing ceramics on all the teeth to control the occlusion. So I know most of you would have looked at that and gone, this is ortho, and you're absolutely right. But if the patient turns around and says no, if he changes his mind, then we would get an ortho opinion in this.
And Riaz, if I could just ask a quick question at that point, because I have a lot of cases where patients may not want to go through ortho. Is there a particular path of communication you could suggest to maybe force them, or not force them, but encourage them down that route? I mean, is no really no the first time that you have that conversation?
I think you've got to look at the patient and what they are like. This gentleman he's a cardiologist. You know, when you communicate with him, this guy knows. You know, so if I've got any degree of uncertainty, they're like, I'm not sure. We pursue the orthodontic route. But if the patient knows with conviction that actually I'm not wearing a brace, that is a no, then you've got to trust. There's no point in getting an orthodontic opinion because he's already said no. So it's that suitability assessment that you're doing, that desirability assessment. You're getting to know your patient. And like I said, this guy, you know, when he says no, it's no. He's not one of those guys that is dilly-daddles on things. When he makes a decision, he makes a decision.
Cheers, thank you.
Whereas like this lady, she's open to suggestions. So when someone is open to suggestions, it's great because it means we can actually really pursue and go through the options for the patient. So this is the lady here who's got some mobile teeth with some recession on the right side. She's got a gold crown on the lower left, the teeth on the top right are mobile. These teeth, she's got quite severe erosion. So that is under control with meprazole, and she hasn't had any reflux or heartburn. But again, we would be still testing that. This gold crown has a refilling and has infection on it. The teeth are ill-positioned. So again, this option here, these teeth were mobile, this could be an option for ortho, but these teeth are mobile, reduced bone loss, so the prognosis of these teeth aren't great. And you can see here, we've got quite severe erosion. But smile design is important. This patient psychologically is quite distressed by a smile. So it's quite important that we really show her what we can actually achieve. But again, this is only a guide, guys. This is not a gold, you know, we are reiterating. This is just giving you a destination point, and we'll show you in your provisionals what your endpoint will look like, and we'll correct it till you're happy. So again, showing smile design. I've already started to talk to her about the best advice, and the best advice would involve implants. So that's her wish list. So she wants aesthetic improvement, she wants predictability, she wants to improve chewing because her teeth are loose on the right side. So she's looking at improving that. So the ideal plan here would be a combination of crown lengthening, some ceramic work, and some implants in the top right. That would be the ideal plan for her. Same on the lower molars as well. And then same for the top. If we gave her a compromise, would be instead of implants, I would look at a milled denture. So that could be with PEEK, it could be with cobalt chrome, depending on what my final definitive ceramic material will be. And then there can be a combination of composite on the posteriors to fix the erosion. So Didier Dici type technique. And the same here, the minimum could be that we could just restore all the upper jaw with composite and just do a Didier Dici technique. We could get improved aesthetics, but we will have some compromise with the predictability and the longevity. So if we look at sort of a video just then, she's decided that she wants to go for the middle option. So we then provide her with all the risks and benefits and go through that to make sure she's fully consented. And then what I do now is I start to design my end point. I already had it as a guide using SmileCloud. Now I'm just importing that data. And these are just some tools I think we will need to embrace at some point. Face scanning is quite cheap. So there's the Bellus, I use the Bellus 3D Pro. And to do a face scan and download it, it's 99p. So, you know, I don't subscribe to anything. I just take a face scan and then I import that into Exocad with the digital scan. And then using the functional movement data that we've collected, we'll do a smile design analysis. But also you'll see in a minute, what's really cool about this is that we can actually look at the way they move with that new teeth design. So we're going to look at how she opens. She actually does have a transient deviation. So there is a displacement issue there. And you can see that from there. So what you will notice from a TMD point of view as well is that if you get the occlusion right, the click will get worse. If you get the occlusion wrong, if you get the occlusion right, that click will reduce. So this is now looking at lateral movement with those design teeth. So you see the data given to them. And this is a lab in France called Emotion, digital design lab, so a pretty good lab. Once we have that data, that then gets put into a mock-up. And so that is my end view for the patient. And I'm having this conversation that this is what we're going to be doing. This is what our endpoint is. And then I need to transfer that into the mouth. At the same time, we're giving them a guide of the timeline. So patients, you know, if you're doing something minimum, it's going to be quick. And you need to give them an idea of the journey and how long it's going to take. So for example, anything more extensive could take 8 to 10 months. And I think that's where we've got to make sure we let the patient know that they could fund this over time. So your suitability, affordability is based on your timeline as well. So if they can't afford it, but they can afford it in stages, we need to look at that timeline to see if we can actually manage it. And I think post-COVID now, these are going to be really the most important pillars that I can give you, is that if I can get you to think about your affordability plans for your patient, and can we tweak the timelines to try and still cultivate some income for ourselves, but actually still give the patient the result that they want, but spread over time. It may even mean that, for example, they were going for the best advice, but they can't afford it now. But it may mean that, well, why don't we do stage 1, put you into prototypes, and we can let that run for 6 to 12 months. At least you've got some of the commitment to the journey. And this is just her in provisionals at the moment. So it's a denture on the right and acrylic provisionals on the left side. So she's now in prototypes, and we're committed to that journey now with her. There's another case. So this is actually a case running through using the whole desirability and affordability, suitability assessment. So patients come in, self-referred for an aesthetic improvement, not happy with color, not happy with shape, and there's a psychological impact to that. So they don't smile, they hide, they've got a lack of confidence with it. And we'll see at the end how that really changes when we do get it right for the patient. So I now know what he wants from me. I've now got to do my suitability assessment to say, can I achieve those goals in the environment that I'm going to work with? So he's done a medical history assessment. I've looked at his previous dental history. I've looked at his oral hygiene. I want to know more about him and his stress levels. I want to know about parafunctional habits. He may not be aware of it. We want to know about sleep apnea and so on. So we'll do a real detailed suitability assessment. We'll then get another jigsaw piece and look in the mouth. So you'll be pleased to know that his TMJ is fine. Recession, he's got Miller's class 1. session, class 3, incisal and skeletal. Then you've got your overjet, overbite, OVD assessments, his functional movements of group function, and his first tooth contact is the upper left 7. The reason why I want to stress that is you'll see on the digital how accurate digital can be if we get it right. And his protrusive guidance is on the molars. So we've got a diagnosis, and I've got a provisional idea of a treatment plan. My main concern is his recession. So I want to bring that gum down. So my best advice for him would be looking at fixing those sort of things. This is his dental charting and his perio charting. He's got a low bleeding plaque. He's got a low bleeding and plaque score after his treatment, because you could see he was bleeding. So we've got him through some intensive, and then I've done a re-perio chart just to check everything before we start. And then there's some radiographs to assess everything from a 2D perspective. And you can see the endos on the upper right 7 and the upper left 7, they need addressing. So that's our suitability done. And now we're looking at affordability for him. So my plan here would be to rehab just the upper jaw as a best advice with a connective tissue graft on his canines to bring that soft tissue down. When you see his smile view, you'll see that he has a low smile line, but I don't trust that when they're not happy with the smile. So I would assume, even though he doesn't show his soft tissue, his gums, once I've got him a nicer smile, there's a chance that he will start to show it. So we talked in detail about doing connective tissue grafting on these canines. And so one of the best advices was an upper jaw with connective tissue. The compromise was not to do any connective tissue grafting at all. That was really it. And then the minimum that I could do really was, there really wasn't a lot in these options that could give him the aesthetic and the functional result. It was kind of all or nothing. We either rehab it, we either do it with a connective, or we don't. And anything else, for me, the minimum was not going to achieve anything that he desired. So there was no point in me starting it. We could have looked at some composites and a new bridge, and there were some simple options. But again, what I understood from him was he was wanting now to have a nice smile, because he'd not had one for a long time. So when you see his smile, you see he's got a low smile line. So we've done our assessment with regards to getting more data from him. You can see the canines, the zenith is really high, so we need to bring that down from an ideal point of view. So the patients, listening to everything I've said, I've shown him the smile design, and if you look at the top left there, you'll see where the gingival gum should be, and it's clearly higher. So, but he's decided not, so he's gone for the compromise solution and not gone for connective tissue grafting. Because we're doing a full rehab on the upper arch, it's a reorganized approach. So we can't trust his current position, so we're going to record it. And there's 2 ways I do this, digitally and analog. So this is the digital way, this is the analog way. And then digitally, all I would simply do is take out that bite record. You've done your upper and lower scan, but I would keep the green stick in there to hold him in that position. And then that is the digital scan done of that. And you'll see in a minute, the actual contacts are on the upper left 7. So as I said, the first contact is on the upper left 7. I'm just going to reduce the opacity in a minute there. And then you'll see that this first tooth contact is upper left 7. So what we're doing there now is going to reorganize the whole occlusion to give him an ICP contacts with, all the teeth touching, but the 7 touching as well. So that's what reorganized will be. And then there's your mock-up. So I need to transfer that now to the mouth. We need to test from that for the patient. So they're just acrylic provisionals in the mouth, and that's a digital scan of the acrylic provisionals. And so occlusion, as you know, I'm a geek on occlusion. So I really like to see dots. It gives me a lot of pleasure seeing a lot of dots.
Yeah, he always criticizes my cases when I show him. I've always loved them, and he says, "Yeah, where's your points?"
Yeah, you know what? On Facebook, if I do the same, everyone goes, "I've just polished them off." I'm going, okay, but no one's taking a picture with them on. It's interesting anyway. I divert. So this is actually a functional.
I think that is a really good point, though, Riaz, because actually we always see cases, especially for the young dentists out there, we see cases all the time that might look visually stunning. We see all these big composite bonding cases, but there's not many people showing reviews and they're not showing the occlusal impact. And actually, I think that's dangerous for the people that want to learn out there, because what you've always taught is get the basics right, get the function right. And from there, if you've got stable occlusion, the rest will follow really nicely.
Yeah, no, it's true. This is not a criticism of all the dentists. It's just that it is difficult to design the occlusal, the restoration, even if it's just a composite, to give back the centric stops. But there are ways. You know, I'm going to be doing a webinar on occlusion and just focusing on how to be able to, you know, adjust and get those contacts back. And there's just some simple rules. But yeah, this is looking at the module, so you can see here. This is now a provisional stage. So what I'm looking for is, have I given back all the contacts? And what you can see here is that it appears that it's heavier on the left side. And the one thing you've got to remember with digital is that with digital, there is no periodontal ligament here. So when we do the actual assessment, you saw from the previous picture, the contacts are actually equal. Here I'm looking at how they chew. So I like to look at functionality and see how they actually chew their food. So this is like a test with chewing gum, or I sometimes use apple pieces if we've got some in the practice, but normally they'll be chewing gum just to see how they actually chew and see whether I've improved the chewing. And then importantly is phonetics, because I've now changed the incisal position. So I've also given him an overjet and an overbite, and we've actually given him longer teeth. So what I've got to be careful of here is that these teeth aren't hitting heavily. They will touch, but as long as they're not causing any pain or any symptoms. So I get him to do 66 6 times, and module records that movement. So you'll see that sort of how his teeth move within that phonetical envelope. Me and Nick did the Fadiani course, and this is one thing I was trying to show Fadiani when we were talking about phonetics and S's. I said, I can show this now on a digital setup. So he's now got the module as well. So that's sort of phonetics. So what you've done is a functional, you've done a phonetic analysis, and the last part is now it's got to look good as well. So rest, and then I like to do a speech one to see how he's talking.
It does. How's the job going? Oh, it's great. Yeah, I finished the training. It's a funny story. We went for a bike ride on Tuesday, and it's just a normal bike ride. It's quite a long one, really funny. Anyway, that night I couldn't move my knee, and the following day couldn't even walk on it. And I was meant to be going to Dublin to get my wings presentation at head office, you know, to get hands laid on by the great and good. And so I couldn't go. I had to cancel. I had to call in sick and couldn't go. I had to cancel the day. So I've got another week to go, and then you don't want to be limping.
So what I noticed from his speech was that the canines weren't right. So the upper right canine looked too long. So from a speech point of view, he was talking all right. There was no speech issue, but that canine was way too long for me. It was too obvious in his speech. So again, just that aesthetic analysis meant that I could adjust those things and get those right. And then that was his aesthetic analysis done. He's now got to decide whether he is happy with those provisionals, the color, the shape, and everything else. And he was more than happy. So we just then simply went from that, and then we just transferred into his definitives. And this is zirconia. So monolithic zirconia with some layered porcelain. And this work's been done by Rob Gandhi, who works at our practice. So I love texture, I love line angles. He's done a real good job here. and certainly black and white looks really nice. But what really pleased me was this photo that he sent me when he was on holiday in South Africa.
It looks like you're there with him, mate, with your background.
I know, but it was just and the story was really funny because he goes, actually now his partner, because she's lovely, she's getting irritated at him because he keeps smiling, and I think about 3 or 4 women have said to him, "You've got a really lovely smile." So he's having, his ego's going through the roof, and his partner's looking at him going, you know, gritting her teeth. So, but and so what that just shows for me is that how much of an impact we can have. So my main message, guys, is that, you know, we're going to come through this, that's for sure. We're certainly made of tougher stuff. I mean, I know this is sort of unprecedented what we've been through, but I know we'll get through it, and I know we'll come out of it stronger. So I think what we want to be able to do is really help our patients try and make the right decision. We don't want them to make a decision and then regret it later on. So some of your patients will be coming back going, you know what, I can't afford that. Well, the option is, do we change the timeline so that we still give them the best advice? So is there a way we can still give them the best advice, but maybe over a longer period? Because what we don't want to do is compromise the treatment and then they're having to redo it a couple of years later. And they will, I know I'd be a little aggrieved if I knew that there was a way that I could have done that treatment plan, but it could have just been more affordable for me. So just remember the 3 pillars, guys. It's desirability, suitability, and affordability. And you want to try and now look at your patients, and you will be getting it for certain. Can I tweak the treatment plan so that the timeline fits with the original treatment plan that we presented? But if they have to change it, they have to change it. You know, my job is not, I'm not interested in putting patients in debt. I just want to get them through this tough time, but also make sure that later on I've not actually caused more damage or I've created more maintenance later on because we had to find a shortcut.
Brilliant.
And questions. I love this slide. It's one of my favorite slides because I know when people think about asking questions, they think it's unreasonable or it's silly or it's frivolous, and it's your life and you've got to get these answers. Thank you, guys. I hope you enjoyed it. I hope you benefited.
That was excellent, Riaz. And guys, for anyone out there that wants to ask questions, if you're having trouble putting questions on the Tubules page, just go on Facebook and just message Elaine. She'll be conveying the questions over for me. Riaz, well, if you don't mind, I'm going to get the questions going before I tuck into my Friday night. I think something you said was really interesting when you're talking about, it's very easy when you go on courses, like when I came back from Fradiani's with you, I saw a lovely patient and it was a proper, lovely, minimally invasive rehab case. And I took all my photos, I did my scans, I got a wax up done. I spent about 4 or 5 hours planning it, came to see her, or she came to see me again to discuss the plan. And after all of it, she said, "Oh, actually, I'm not bothered about any of that. Can't you just make a night guard or anything?" And it was me that was fully to blame for that, because I didn't have the foresight to have that straight conversation. What is your goals? I didn't listen to it. I just thought, yes, this is going to be a lovely Facebook case. Woo! But actually, I didn't actually take into consideration what she wanted, and also financial. And you did raise a really good point that people don't have to pay for this all up front. You know, you take some at the provisional stage, you then take some next year or year after. I've had cases in provisionals for 2-3 years. Sanjay's had cases for 7-8 years. You know, you manage around the patient. But what I've learned after 10 years is you don't compromise if you don't feel comfortable. I've done it before and it always comes back to bite me in the butt.
And that's my minimum option. It's the minimum that I will do that I'm comfortable with, that I know can still give me some predictability. So I don't want to just do something and then, like I said, I'm having to deal with the mess a year, 2 years later. I'd still my minimum is still a good option for the patient. It's just the minimum that I will do that can still fulfill their desires. But there is a compromise somewhere. So for example, composite versus ceramic. I'm not as good as you, Nick, for your for your composite work. So I know that my ceramic work is going to be better than my composite work. So if they want composite and they want it to look amazing, then I maybe would put them with someone else in the team that I know's their composite work is really good. So they still get a very good result, but they get it for the cost and they get it done by someone who's really good at that work.
We had a really good comment through from the one and only Ian Hutchinson. Hutchie, good to hear from you, buddy, and hope you're keeping well. Hutch, regarding the thing about patients saying no to orthodontics, Ian's given a great comment to say, you've got to educate the patient. It takes time. It's all about communication. And if after all of that, at the end of the day, they say no, then so be it. But the important thing is that you've tried, you've got proper informed consent, you've covered discrete and invisible devices, and in some cases, you've got options like Invisalign. But it's a good point, I think, especially with the litigation and how easy it is for us to get in trouble. I think having that in our treatment plan, that we really strongly recommend orthodontics, is, I think, key. And if the patient then chooses not to, then so be it.
Yeah, I mean, this case here is quite important because his first tooth contact is on the canine. So actually, when I increase his OVD, the only tooth touching is his upper canine and his lower canine. So actually, from a restorative point of view, to correct that sort of crossbite, actually restoratively isn't as challenging as you'd think when you look at it there. So if it was really challenging restoratively, then I would not be doing it. Restorative wouldn't be a solution, because in my suitability assessment, I actually can do something restoratively, which involves having to work on reducing the incisal length of the upper canine, lower canine, and it's about two mils. So it's like what you would do for a veneer. And actually just adding to the buccal of that canine actually gives me back some stable centric stops. So we've done the design on it. Again, it's all that prep. But if that wasn't achievable, I wouldn't even be, restorative wasn't the solution. It's because it was a solution through our suitable assessment. But as Ian said, and absolutely spot on, we offer Sure Smile. So we have an orthodontist on site. So I'm lucky that I can actually say, look, you know what, it does need an orthodontic assessment. What interesting with this guy is that he's a top-notch cardiologist. He knows what he wants, and I've shown him lingual, I've shown him everything with the consent side, and gone, look, we can do invisible. It's not so straightforward invisible with that, because you're going to need arch expansion. So you're going to need involved ortho here. This is not a straightforward ortho case either. You're going to have to expand the arch to correct the crossbite.
So we've got, yeah, absolutely right. We've got another really good question, actually, which is something that I have to answer quite a lot. And as a young dentist, it's a tough one. And that's when you're comparing your options, composite and ceramic, how can you advise your patient with regards to the longevity? So for composite, for example, what should we be telling our patients how long these are going to last for compared to ceramics? And again, while there may be an initial financial advantage to look at a composite, over the long run of 10, 15, 20 years, with the fact composites need more maintenance, does it really work out in the long run much more conservative financially?
Yeah, that's the key. There's actually quite a lot of papers on this, and the figures vary. So you can have, for example, like Dahl type composites, their wear rate and their lasting anything 4 to 5 years, and some papers say 7 to 8 years. So you're going to get a variation there. The key here is your suitability assessment, because if their power functioning, their wear rate is greater, then the risk is whatever material you put in will wear at a faster rate. So that means we need to put some protection in to stop it from wearing. So that may be a hard guard, on the upper or so on. So That's key, is first your suitability assessment. Composite will work. Ceramics depends on your skills. So I've been 20 years, so I can show ceramic cases that are now, I've got a 15-year case, 15-year case. So that's one case that's 15 years because they followed me for 15 years. But I've been at 3 or 4 practices in 20 years. So not all of the patients have followed me, so I can review them all. But I know that we expect ceramics to last 10 to 12 years plus. But the example is a car. You can buy a Mercedes or you can buy a Fiat. The key here is how you look after it, how you service it. So if a patient has whatever work you put in composite, they need to be coming back to you for servicing, coming back to you so that you can review it. And that is a key, one of the key criteria for any work that I do. If there's ever a problem, they've got to come back and see me, because it's my problem to fix. And I want to know if the work isn't work, if there's failures. So,
and I think part of that also is understanding what level of aesthetics the patient craves. Like you mentioned, if you see some patients that will look at things with a mirror right up against their face and be critical of every single thing, and then you've got other patients that just want to be healthy and have things looking great. And it's understanding their needs as well as what we think is right as well. But it's interesting what you said about the maintenance. And I think what you've, speaking to people like yourself and Sanjay and Mauro, and it's also how we understand these materials in occlusion as well. Whatever material you put on, if we're not understanding how we're getting even contacts, if we don't understand how to use articulating paper and adjust things properly and obtain good even contacts, then the risk is anything you put on will fail. And the issue with ceramic is the failure is much bigger. At least with composite, if you've not messed it up, but if you've got a bigger margin of error to correct if things aren't quite right in composite. Would you agree?
Yeah, I mean, Torbajima's paper put this in sort of quite good context. He said, look, for your restorative materials are great with compressive forces, just poor with tensile forces. So when you're trying to do all the contacts, you're just trying to make sure that the forces are all compressive, and therefore your restorations will last longer. If you put them under more tensile forces, they'll just fail sooner. So your occlusion is really important.
We've got another question from Amapal Singh Midda from up north, who is shortly going to be joining our Square Mile team. How you doing, buddy? Nice to hear from you. Amit's raised a good point. How do you bring up the topic of the patient's budget without sounding like you're trying to come across as money grabbing, instead of showing them that you're trying to offer them the best for care?
It's in that suitability stage. So right at that suitability stage, I'm going, look, I can deliver what you want, but there's 3 ways that I can do that. And affordability. And I actually do say to them, look, it's the white elephant in the room. I know you're waiting, and I'll make a joke of it. So I think it's important that you don't take the costing elements seriously, and you don't get offended when they go, oh, I don't want the best advice, I want the minimum. And so there's no offense there. Because if you get offended, you take it personally, then yes, you've attached something to that financial, which, like I said, the end goal here is the patient result and the patient being happy, and me being happy as well. But the end goal is patient satisfaction. So,
Sanjay's just messaged saying, if you want the patient to feel more comfortable about giving you more money, just dye your hair grey. Look a bit wiser and older. We've got another question that's just come through. Riaz, lovely work. What is your system? A 2-visit new patient process or a 1 visit? How do you present your findings? Do they take something in their hands like a treatment plan on the first, second stage? Or do you opt for digital technology or a photo plan? Zach, thanks for that question. That's a great question, because at our practice, I'm trying to introduce anyone over a certain value or certain complexity, I'm sending them a PowerPoint photo plan where I'm pointing with arrows to this tooth needs to be there. We've got failing amalgams here. And I feel that if patients don't necessarily take my treatment on straight away, they will come back because they won't get that level of care from another practitioner. They won't get that level of attention to detail. Everyone's just trying to bash out a treatment plan very quick. But how do you go about your plans and what's your protocol from new patient to treatment plan?
So I'm pretty straight with the patient straight away. So once we've understood their desires, so normally what happens is patient comes in, they don't come into surgery. So what happens is they're in the treatment coordinator room. It's a relaxed area. There's no dental chair. We just chill for a good 10, 15 minutes because I actually really want to understand the patient. So that 5 in 10 or 15, if it's a simple, let's say I want an implant. Okay, that's straightforward. Or I'm wanting to improve my smile. That's a bigger conversation because I need to understand what they understand by their smile. What are they unhappy with now? So I know that I'm going to try and fix that. So that's your initial 10 minutes, 50, it could be longer. Sometimes with TMD patients, it can be half an hour. So, but once I've understood their desires, they're into the suitability room, so to speak. They're into the clinical assessment. If I can look in the mouth and picture my sort of end goal now, then I'm sort of quite comfortable having a conversation now. But if I'm even a little, I need to think about this, then I'm really straight with the patient. I'm just going, look, the reality is what you want is challenging with the way your mouth is. So what I want to do is get as much information from you today, and then I just need to sit at home and think about it so I can actually plan your destination. I like to talk to patients in terms of destination. So, and I like to laugh about it and joke about it. So I'll say, look, there's 3 ways, and best advice may be New York, for example. So, and compromise may be Paris, and minimum may be London. So they're all destinations, and obviously London doesn't take as long, certainly not in sort of the current climate. I know if I got on the motorway, I think I'd get to London I'd get to Nix in about an hour and a half. Roads are absolutely.
Essex is unusually quiet at the moment, Riaz. It'll be back to normal.
And if I wanted to go to Paris, then that's going to cost a little bit more, and it's going to take a bit longer, and it's going to involve more work.
Wait, I'm not quite sure I'm happy about you using Essex as the compromise plan here, by the way.
No, that's the minimum plan. It's even worse.
We've got another good question by Frank Goulburn. How you doing, buddy? Great to hear from you. Riaz, you're not using DSD. You did mention the name of the similar software, but do you mind just repeating that?
Of course, Frank. It's called Smile Cloud by a guy called Florin Kafar. Now, what's interesting about Florin is when he does his treatment plans, he does the same as me. But if they want anything below best advice, it goes to someone else in the practice. So he refuses to do anything below best advice. So that's the model he has at the practice, because his attitude is, if they want me to do it, then it's this way and no other way. Now, that might work in Romania. He's in a place called Timisoara. It's a little bit more different in the UK, where we've got to be a lot more hot on the medical legal side. All
right, we'll take a couple more, but I want to keep this short as we promised. We've got a great chap, Anish Patel. Anish, good to hear from you as well, buddy. Many thanks for the presentation, Riaz. With large rehab cases, when the written consent is formed and shared with the patients, do you find sometimes they can get overwhelmed by the consent form? How do you manage this? And like everyone is hoping, if you've got some form of plan or a summary sheet that at some point you could share with us.
Yeah, sure. So yeah, there are some bullet points. I think the journey for consent has been quite thorough when you come to do your first assessment. And then I will do, like Nick was talking, I actually do the presentation. So that presentation would be done with them. Once that presentation's done, it's then if they've decided to go for best advice, then I simply write that in the letter saying, you know, great to see you. We've discussed 3 options. You've gone for the compromise. This is what that involves. So that's the key. I think consent for me has always been part of, when I used to work at the dental school, I just sort of simply transferred that over. And it was always, you know, explain the procedure. So I have a table, and in that table, I will tell them exactly what treatment I'm doing, how long that treatment appointment is for, what that treatment involves, who the clinician is, because sometimes if it's complex, it may involve another clinician, what they need to pay at that appointment. So I'll actually give them a real detailed breakdown. That has several advantages. It also helps my team, because what they do from that table, they make all the appointments. The consent part is a list, but again, it's terminology. If the patient doesn't understand terminology, you can give them a list, but you don't know if they understand it. And the key is, how do you know you understand it? It's that verbal conversation going through the treatment plan. When they come in to then start the first phase, and the first phase as a standard for me is data collection, we go back through it to make sure they understand everything. So consent actually is a 3-step process. It's your initial consultation, it's your presentation with the letter, and then at data collection, we really nail that they've understood the letter, and then they sign the consent and the treatment plan at that stage. But they won't sign it until I've had that conversation. Sometimes in the letter, I will say, we need to have a conversation to really help you understand what I've put in that letter. So you can only do the best you can.
I remember having a good chat with Neil Jaswell, and he gave me a great idea, which I want to enforce actually. And that's when you're going through the treatment plan with a patient on your computer or through photos, give them a pen and pad and just get them to jot some notes down, and then ask them to read it back to you just to see if they've understood exactly what you're planning. Because as you and I and most people know, patients may nod and say yes, and part of the time they're nervous. You know, no one likes coming to the dentist, and even though we think we're great communicators, our message may be being lost because the patient isn't as comfortable in our environment. So having them write it back down.
I know you're bored.
Oh, okay. Then nice way. Drew, we can hear you, buddy.
I'm off now.
No worries. That was a good idea to have a patient write down what we've gone through with them. Kate on Bike Club Tubules has just said, can you mention the equipment you use to record the chewing motion again?
It's called ModJaw, ModJaw. If you have a look on squaredentaledu.com, that will show you a lot of videos on functional movements, and there's a YouTube channel as well. But yeah, it's ModJaw. It's a great tool. But you know, if I'd known that COVID was happening, you know, that's not a cheap tool. It's about £25,000 for that tool. So, you know, it's not a small investment. That, you know, you've got to have the cases coming through that can potentially fund your justification. Now, I'm a geek, so I do it from a research point of view. So it helps me understand why I do what I do. So I'm happy to fund that myself rather than rely upon patient cases coming in. I just want to know what I'm doing, understand things.
Well, if my brother Sanjay is listening, then you know what I want for my next birthday present, a ModJaw machine, nice and new for when we go back. Riaz, that's been fantastic. It was a fun start to our Geeking Out in Lockdown.
Oh, no, brilliant.
I'm looking forward to your one. With you on the beach, I feel like I need to be wearing my Bruno Mars baseball cap to be finishing this.
Wait a minute, I've got glasses too.
I got the sunnies as well.
I should have put my glasses on, shouldn't I?
I've also got my tequila ready as well because it is Friday. And let's be honest.
Yeah.
Nice.
Well, I don't drink, so.
Guys, thank you so much for tuning in on Sunday at 2:30 p.m. If you go on the Geeking Out in Lockdown Facebook page, like the page, and the link is already ready. Sunday at 2:30 p.m. We've got my brother, my mentor, Sanjay Sethi, who's going to be talking about decision making when it comes to a compromised anterior tooth. It's a really interesting lecture. There's 10 different ways you can treat it. But he will show you and justify why he did the way he did. Riaz, thank you so much for your time. And guys,
well done.
we look forward to seeing you all again soon. Stay safe out there and happy Friday, everyone. See you later. Elbows.
Brilliant. That's amazing, actually. So thank you, guys.
Thank you, Drew.
And Geeking Out has taken off now. So we will be seeing you Sunday 2:30. Riaz, some amazing tips there. Nick, you can't go out. I would have said get some new glasses. But we're all off out to get some fresh air. And what are we talking about on Sunday, Nick?
It's Sanjay Sethi doing management of a compromised anterior tooth and the different ways it can be treated. There's no one path to treat a compromised tooth, and looking at an evidence-based and discussion of why he chose the route he did. And it'll be a great lecture. And then you've got me, unfortunately, guys. You've got to listen to me on Tuesday at 7 o'clock talking about managing deep subgingival margins, something we all face with daily. So hopefully we'll be seeing everyone there.
And as we said, if you do want to check out all the Geeking Out live webinars and where to go with them, remember, you can go on the website, you go onto Tubules Live Aid section, you look at the webinar area down here, and you will see the list coming up. We're going to keep loading them as they come along. 12 super Tubules Live togethers. We have to do this together, and we are doing them. So brilliant. Thanks, guys.
Thank you very much.
Enjoy your time in Barbados, and we hope you get a flight back in the next month.
That's it. I'm going to go kill now. I'll see you later.
See
See you later, everyone. Take care.
Okay, guys.
Thank you.
Bye.
I'll finish that.